Welcome, everybody. My name is Stephen Hansen. I'm the Director of Graduate Studies for the Master of Science in Bioethics and Medical Humanities at Tulane. And the Bioethics Interest Group at the School of Medicine has asked us to assist with this, and they've set up this talk, and I give them all the credit for setting this up. I would simply like to invite anyone who is here who may be interested in the topics discussed here or other topics of bioethics and medical humanities to look at, to feel free to look at our program at tulane.edu/bioethics. We are also having an information session for the program tomorrow at this time at noon. And if you are at all interested in joining that information session, please just send an email to medical ethics, all one word, at tulane.edu. And I will be more than happy to, add you to that list, and we'll talk to you at that point. So, without further ado, let me hand this over to Grant to introduce our speaker for today.
Hello, and we welcome Dr. Faith Fletcher. Here is a bit of introduction, but I'll leave the rest to her. Faith Fletcher, PhD, MA, is an assistant professor in the Center for Medical Ethics and Health Policy at Baylor College of Medicine and a senior advisor to the Hastings Center. Her empirical research over the past decade focuses on healthcare and research experiences of minoritized populations to inform ethically grounded and community-centered practices and strategies. Dr. Fletcher received training through Fordham University's HIV Research Ethics Training Institute and is a contributor to the American Public Health Association's New Code of Public Health Ethics. In 2017, Dr. Fletcher was named one of the National Minority Quality Forum's 40 Under 40 Leaders in Health for her commitment to improving access to scientific research and quality healthcare for medically underserved populations. This prestigious award acknowledges the next generation of leaders primed to reduce health inequalities. Thanks, and without further ado, over to you, Dr. Fletcher.
Thank you so much for that introduction. Thank you to the Bioethics Interest Group, as well as the Department of Bioethics at Tulane for having me here. I'm also a Louisiana native, so it's always an honor engaging with Tulane and other Louisiana friends. So I was gonna say, I wanna highlight that I think people are still trying to come in. So I don't know if someone else wants to admit people, and I think I have.
I agree.
We will take care of that.
You can ignore it.
Okay, great. So let me get started. Okay, so I will today discuss, as mentioned, health equity in the context of healthcare. Why does it matter now, and why does it matter beyond the COVID-19 pandemic? Again, I am an assistant professor in the Center for Medical Ethics and Health Policy at Baylor College of Medicine, and my research focuses broadly over the past 10 years or so, really trying to understand the healthcare experiences as well as the research experiences of populations that are traditionally and systematically marginalized and stigmatized. The group that I've worked the most with includes Black women living with HIV in the Deep South who embody multiple social marginalized identities. Again, my focus is understanding more about healthcare experiences. I do this through a number of methods. This includes qualitative methods, a combination of qualitative and quantitative methods. Again, my training at Fordham University really helped to give me some insight as to how to use these perspectives of populations that are marginalized and to really be able to integrate that into research protocols and practices with the intent of mitigating harms amongst populations that are traditionally marginalized, So one example might include when we are recruiting populations in my work with HIV positive individuals, leaving flyers at clinics. And if a person might pick up a flyer that says, hey, come out and participate in our study for people living with HIV, if someone discovers that flyer later, it could lead to a number or a multitude of harmful consequences. So again, just being very sensitive in the ways that we recruit, the ways that we engage populations, and even the ways that we disseminate information in order to minimize stereotyping and discrimination that's, again, germane to populations that are socially disadvantaged. So I'll begin by talking about health inequities compared to healthcare inequity. So years ago, a lot of people were using the language of health disparities. It's still used, but in my work, I'm very intentional about using the language of health inequities. So an example might include, a question that I generally pose includes, are the differences in health statuses or health outcomes, are they unjust? Are they avoidable? And are they unfair? And this is really important, again, in the context of just understanding differences. Differences alone don't necessarily equal health inequities. So disparities versus inequities. In the context of healthcare inequity, I think about this in terms of care. Is the care affordable? Is it acceptable? Some care sometimes is not acceptable. Is it available to individuals? And this is really important, especially right now in the context of the COVID-19 pandemic. When we think about healthcare inequities, I immediately think about Dr. Susan Moore, who was a physician who died from COVID-19. But what's unique about Dr. Moore is that she documented her healthcare encounters and experiences via Facebook Live when she felt that she wasn't being treated equally or equitably. She stated, I maintain if I were white, I wouldn't go through this. She highlighted levels of pain that were ignored. She felt dismissed in the encounter. And I think we really need to use this as an opportunity, teaching in medical education, as well as in public health, when we think about historical injustices, always highlighting that these contemporary injustices really reinforce the narratives that healthcare systems are not safe for Black and Brown individuals. It's especially important in my work. I like to highlight that, again, individuals have different levels of discrimination and inequity based on their intersections of maybe race, gender, sexual orientation. There's lots of literature that expresses differences in treatment based on weight or obesity stigma, poverty stigma. So thinking about all the ways that these identities might influence healthcare engagement and potentially the outcomes that people receive. I just want to say one thing that people coming in, it's kind of blocking my PowerPoint. So if there's any way to remove that, possibly. If not, I'll just try to power through.
Okay, I'm sorry. Does it block it now?
I don't see it now, but as soon as someone comes, it's going to come up on the screen. It comes right in the middle of the screen.
Okay, let me see if I can move it.
Thank you.
Okay, you can.
And I'll keep going. And again, I'll do my best to just sort of ignore the pop-ups. So again, healthcare inequities, we still ask the same questions as healthcare, as health equity researchers. Are these differences unjust? Or are they avoidable, and are they unfair? So finally, again, just moving away slightly from the conceptualization of disparities, we really aim towards achieving health equity when every person has the opportunity for full potential, that no one's disadvantaged based on their social position, their identities, or other socially determined circumstances. So when we think about health inequities, again, in the context of the COVID-19 pandemic, I'll just highlight that there are There's lots of documentation that there are differences in COVID-19 incidents, so the number of new cases, COVID-19 severity, and COVID-19 death. And here, thinking compared to white, non-Hispanic persons, we see that African Americans, Native Americans, as well as Hispanics have different health outcomes. I raise this to say, well, one thing, we do see that there are, the differences are narrowing based on the COVID-19 vaccination. So we do see that there's higher uptake. There's a lot of efforts from community agencies, as well as activists, healthcare providers, other healthcare leaders, really working to minimize barriers to COVID-19 vaccination uptake, going to communities, meeting people where they are, many initiatives. One that I think is especially innovative, Shots at the Shop, where colleagues at University of Maryland are partnering with other beauty salons and barbers throughout the US, Black stylists, really training them and engaging them, providing them with the education to deliver COVID-19 information to communities that may not generally receive information, maybe in healthcare settings. And this has been a really important movement in terms of, again, meeting people where they are, alleviating these barriers, but also just thinking about the concept of changing health and healthcare, that it takes a village. We can't do this as professionals without the help of stakeholders and engaging other individuals who are not only leaders in the field, but also have influence potentially over other peers that health professionals may not. So again, important to leverage their lived experiences, their contextual experiences, and their expertise. I also want to highlight here what these differences are inequities, excuse me, in health outcomes, that we want to avoid the notion that there are some individuals that are riskier than others. Again, we hear these narratives promoting a lot, and it's important to think about fundamental root causes, the concept that individuals live in these environments, the environments that they live in, the social and physical environments that they live in, really set the stage for an individual being able to easily engage in healthy or risky behavior. And some examples of the social environment include discrimination, as I highlighted earlier with the Dr. Susan Moore example, income inequality, physical conditions such as the built environment. Is your neighborhood crowded? Are you living in spaces that provide access to public transportation? The good news is that these social determinants of health, or these non-medical factors, are not unique or inherent to an individual. These factors can be modified through political will, interventions, engagement with communities, and just the collective approach to alleviating health inequities. So this is a good news as it relates to health equity. There's space for change. Again, the framing matters. And one piece that I always highlight in the context of my work, again, people live in risk. And this is a result of these complex, integrated, overlapping social structures and economic and other ecological systems. Examples include individuals who may not have access to testing. So earlier in the COVID-19 pandemic, especially, people reported, hey, there's a drive-through testing site or center, but I actually don't have access to transportation. Or the testing site was just too far away from individuals who were more socially disadvantaged, and persons weren't able to get tested. Of course, individuals living in areas that are highly polluted, higher density, all of these factors, of course, combine and really increase or heighten risk for certain individuals. I also want to highlight my colleague, Dr. Claretta Dupree, in a recent conversation about health inequities. She highlighted that essential workers are also based on patterns in US history and just the current dealing with individuals in this pandemic. They're also expendable. And we have to, again, change that and make sure that we're delivering the same level of care and prevention services to all persons. So it was mentioned that my background really is at the intersection of public health, specifically health behavior, as well as ethics. And in my work, it's important when we think about changing behavior has to happen at multiple levels. So we think about this in the context of the socio-ecological model, understanding these dynamic interactions at different levels, the way that these levels interact. When we think about changing behavior, sometimes we address behavior at the individual level, when really the behavior change is rooted in the context of an institution or a policy that might make it difficult to engage in such behaviors. So we sometimes really miss the mark in terms of promoting behavior change amongst certain populations. We, as in public health professionals, as an ethicist who are working to analyze and conceptualize these issues and offer solutions, as in healthcare providers who are engaging with patients and don't fully understand the context, individuals' lived experiences for the behavior, and leads to stereotypes such as certain populations are generally non-adherent. So we want to, again, really work to change those really flawed and harmful narratives. We often target the wrong level. I mentioned looking at the individual level when the change is really rooted in the system or the institution or the policy. Sometimes we have to address this change at multiple levels. So if it is based on changing individual knowledge, we might also have to engage community policies or institutional policies in order to do that. So one of my colleagues refers to this as sometimes we just, address the low-hanging fruit. So we know that systemic and structural change sometimes can be a very long process. So maybe in our grants and our programs, we really work towards highlighting individual behavior or personal responsibility. We can really make an impact if we change individuals' perceptions about something. And again, while those things are important, we know that this may not be critical enough to sustain behavior change. Education programs and health campaigns are important, but we also need, again, more institutional level, more policy change, more political will to really change and also maintain behavior change. And of course, it's always important to engage communities. So developing health campaigns or educational campaigns without doing some pilot work or some formative work with communities sometimes doesn't always work out as well as it should. So if we're going to use resources, we have to make sure one of the first things that we do is engage communities, understand what their barriers are, understand what those facilitators might be as well. So along the lines with this individual responsibility, as well as the narratives that we use that can be harmful, I recently co-authored a paper with colleagues where we talked about these negative frames and that these frames are very much embedded in our research processes, even our healthcare engagement processes. We refer to populations as vaccine hesitant, especially minority populations, without providing any context to understand what these concerns or what questions communities may have. Black race is a risk factor. We hear that a lot. We teach that in both medical as well as public health settings to students. Communities are inherently distrustful. They're risky. They're vulnerable. Bioethics language, they're hard to reach. Again, it's really important to really evaluate and interrogate our use of this language, but also work to change this narrative so that the responsibility is placed on institutions and on policymakers to really make behavior change easy for populations. Along the same lines of individual responsibility, this individual mistrust and distrust is something that I recently discussed with colleagues in an article where we highlighted that individuals are not inherently distrustful. It's important to think about distrust shaped by these collective experiences, using terminology such as trustworthiness. My colleague, Dr. Stephen Shadecki, is also on this call and has done a lot of work in the past discussing the importance of building a culture of trustworthiness. So this is something, again, that's key. It's critical to behavior change, but also promoting health equity. Thinking about institutional distrust as accumulated over time. And some even think about it in terms of being transferred intergenerationally. So even if I didn't experience distrust, I might have heard from an elder that, there's instances where, distrust was very pervasive during a certain time. So maybe vicarious experiences of distrust. But when these aspects of these experiences, these negative experiences, sometimes have not been reconciled, and we just continue to perpetuate and reinforce through our medical systems, through our research systems, through the public health systems. So if we really are committed to change, we have to start thinking about engaging in critical reflection, courageous dialogue, documenting some of these injustices, and also acknowledging to communities that they're real. That's key, again, in order to promote health equity or a culture of health equity. So I want to spend a few moments talking a little bit about truth and reconciliation. So we're hearing a lot from organizations. The good news is we have our leading health organizations finally acknowledging that racism is in fact a threat to the public's health, especially the health of communities of color, populations that have been socially marginalized. We see movement. There's definitely an opportunity to build on this momentum, programs that are being developed, practices and policies that have resulted from this. So I just want to spend a few moments talking about what the leading organizations are saying and what some might be doing, and the importance of maintaining this momentum and really holding these organizations accountable, as my colleague, Dr. Keisha Ray, highlights in the bioethics space. So in April, the director of the Centers for Disease Control and Prevention, or the CDC, highlighted that racism is a serious public health threat. It directly affects the well-being of millions of Americans. It's not just the discrimination against one group based on skin color or race or ethnicity, but it's the structural barriers that impact racial and ethnic groups differently. Not only does this impact individuals' experiences with the healthcare system, but also where people live, where they work, where their children play, where they worship, multiple facets of life. Again, these social determinants of health or non-medical factors have lifelong negative effects mental, physical, emotional, and other aspects of health amongst communities of color. Recently, the National Institutes of Health, or the NIH, apologized for structural racism. Activists have long highlighted that there are disparities or inequities related to who's receiving grant funding. Again, we're starting to collect data and document these inequities. What people have suspected all along, that there are disparities based on awarding grants, based on topic choice. There are some things that really serve to prevent certain groups from receiving funding. So we definitely have some issues there that need to be addressed, but we have an acknowledgement that this exists. And again, that's the first step, really acknowledging and being truthful about the harmful effects. So Dr. Collins states, to those individuals in the biomedical research enterprise who've endured disadvantages, I'm truly sorry. NIH is committed to instituting new ways of inclusion, identifying and dismantling any policies and practices that our agency might harm our workforce or our science. And just a few days ago, the American Psychological Association also made a statement. They acknowledged that the apology should have come a little earlier. Again, when we're thinking about mental, emotional health, stigma populations that have these enduring effects of trauma and stress, chronic stress, intergenerational stress, it's really important that APA is also leading this conversation. They recently apologized and talked about their responsibility and structural racism and is working towards more conversations and hopefully more strategies and programming to circumvent structural racism and to address it. And the American Medical Association, I saved AMA for last because they, in 2008, also made an apology. They acknowledged their role in perpetuating structural racism. More recently, they've instituted policies that really work to help to address public health or structural racism as a public health issue. In 2018, they established the Center for Health Equity. This center is led by Dr. Aletha Maybank, who's made some really critical and I believe long-lasting steps to promote health equity and medical education and healthcare systems and health spaces broadly. Their center acknowledges that it's important that physicians, those who are also training, have the tools, have the resources to really confront inequities, to dismantle white supremacy, to address racism and other forms of exclusion, structured oppression. And what's key here and what AMA has, the Center for Health Equity has really highlighted is the importance of embedding racial justice across all aspects of health systems. And here are just a few examples. There's a recent health equity strategy that was released. Recently, there was also a guide to language, narratives, and concepts. So I talked earlier about my work and my commitment to also promoting language that is that's really rooted more in a positive light, that really highlights assets of communities. And AMA has put out a wonderful resource. There's been some pushback against the language, some of the language that's being used, but if you haven't taken a look, I really recommend that you read this resource with a critical eye, but I think it's an important resource that we use for medical education as well as public health education. And again, some of the pillars include embedding equity, ensuring equity and innovation, addressing things upstream, and finally, fostering truth, reconciliation, racial healing, and transformation. So where do we go from here based on some of those commitments, those pledges, our leading health organizations acknowledging that it's racism and not race, that's a social determinant of health. It impacts communities of color in negative ways, and we have to do something about it. So with Dr. Aletha Maybank, we recently commented in the context of COVID-19 and really beyond, what are the ways that we can make vaccine rollout more equitable? So this was several months ago. People were talking about, so what do we do? Are there still going to be communities that are left behind? And some of the things that we thought were important to highlight is that we have to really recognize that people have very real barriers to equitable quality care. Again, I used the example of transportation, lots of drive-through clinics for individuals. Many individuals don't have access to transportation. We have to acknowledge and respect and address people's concerns as being real instead of dismissing them and then just saying that populations are distrustful or hesitant without actually seeking knowledge, seeking greater understanding. Empowering choices with truth and transparency. We know Dr. Alice Stanford in Philly has done a really wonderful job with, again, providing communities with information, but really addressing barriers. So when individuals are not able to get to a testing or a vaccination site at, I guess, 8 a.m., between 8 and 5 p.m., Dr. Stanford and other colleagues have really worked hard to have 24-hour clinics, lots of workplace, lots of flexibility for individuals who can't just leave work, people who aren't working from home, people with transportation barriers, making sure that we're bringing vaccination sites and other testing centers to workplaces, to churches, and as I mentioned earlier, to salons and to barber shops. And finally, as health professionals and individuals really engaged and interested in health equity work, sometimes we have to realize that we're not always the best people to deliver the message or the information. So this requires cross-disciplinary collaboration, engaging other individuals who may be better messenger deliverers. So that's something that is important, that again, it takes a village. So beyond the COVID-19 pandemic, we've learned a lot of lessons, and there are a lot of things that we should be doing in order to really improve in the delivery of healthcare and within a health equity lens. Strengthening the public health infrastructure, strengthening public health education is something that we've become aware of, that many individuals don't necessarily even know the function of public health. They're aware with medicine, but not necessarily public health. So lots of opportunities for education at the earlier levels related to public health. What are some of the traditional public health interventions? What does it really mean not to know that an intervention is actually working and being effective? Addressing these social determinants of health, confronting racism in healthcare. And I specifically want to highlight anti-Black racism in healthcare. There's a unique history for individuals who are Black in the US. And we're seeing that, there are huge inequities related to the maternal maternity mortality crisis amongst Black women. Lots of grant funding right now to really understand and address these differences. There is a need to really empower individuals who are in healthcare settings who may feel vulnerable to speak up, to continue to, like someone has said recently, if you feel like something's wrong when you're in these settings, make sure that you notify someone. And if one person doesn't listen, make sure that you try to find someone else. Again, we know that there are many women in these situations who do report high levels of pain or feeling like there's something that's not right within healthcare systems. So we have to make sure, again, that there are people who can help to mediate these situations. I've recently had more conversations with clinical ethicists, for instance. What's the role of clinical ethicists in addressing structural racism? Could clinical ethicists possibly serve as mediators in situations where women and families are in situations where they feel like they're not being heard, where they feel like discrimination and racism is occurring? Again, quoting my colleague, Dr. Keisha Ray, we must hold organizations accountable. So it's one thing to make statements and pledges and declarations, but it's really important that we are able to follow and see change and really to measure change that should occur post acknowledgements and post apologies. So in the last few minutes, I'll talk about what are the implications for the field of bioethics. So I've talked about health and healthcare and equities, which has direct implications for bioethics and people working in bioethics spaces. So just to highlight a few aspects, we know that bioethics is concerned with health and healthcare issues and other sorts of dilemmas, but scholars have long highlighted that there's a lack of attention in the field of bioethics to racial justice issues, to health and healthcare inequities, a lack of respect for the values and the lives, the lived experiences, the moral dilemmas that may even be daily dilemmas as a result of structural inequities and inequality. This might extend beyond maybe acute issues that might happen in healthcare systems. So it might not be death and dying, like it literally might be the experiences of Black women who are faced with discrimination in healthcare settings. So these are some of the things that are important to really amplify, to highlight in the bioethics literature. And we can only do that if we create safe spaces and structures for Black, Indigenous, and other people of color scholars to connect, to receive mentorship, to engage in bioethics, to learn about bioethics, to publish in bioethics. It's important that we, again, highlight the scholarship that we're citing this work. The work is out there. Scholars have, again, long written about racial justice and health inequities in the field of bioethics, but because of issues related to racism and just inequities in the field of bioethics itself, some of this work remains virtually invisible. So we want to really bring this work to the forefront. And part of my commitment as a person who was exposed to wonderful mentorship and intergenerational mentorship in the field of bioethics is to really acknowledge and to pay respect to those individuals who mentored me and others in the field of bioethics by bringing their work back to the forefront, highlighting it, making sure that it's included in syllabi so that people are learning about this rich critical work that was often ignored, referred to as identity work, and not really considered to be real bioethics issues. Recent work with colleagues, Dr. Keisha Ray, Dr. Virginia Brown, Dr. Claretta Dupree, and even Dr. Patrick Smith, who is not part of this panel, but also has really been working with me in helping to lead an initiative, an anti-racism initiative, which is a collaboration with the Hastings Center. Several members of a committee, a steering committee that really helped us to develop this work, helped us to develop the special report. I'm not sure if any of these people are on the call, but if you are, again, I really want to thank you for helping to really usher this work. I know Dr. Stephen Shadecki has been there since day one, really helping to, again, implement these anti-racism and bioethics initiatives. So a lot of bioethicists, many work in medical education and medical schools and are able to deliver some medical education. And I want to highlight my former, well, she is doing some work with Baylor, Falashade. Lapita did a wonderful job this summer as a fellow at Baylor, helping us to think about medical education in the context of health equity. So I really thank her because she really reinvigorated my interest in medical education and health equity. And here we really highlight the importance of, again, bioethicists being at the forefront of racial equity work, of health equity work, changing the delivery of medical education to students, highlighting structural competency versus cultural competency, really implementing and employing interdisciplinary approaches to medical education, including using lenses such as Black feminist thought, other public health, other justice-oriented frameworks, critical race theory, to really deliver this information in a way that describes the lived experiences of populations, the barriers, the resiliencies, and other aspects of people's lives. Also important to highlight the history of medical abuse in the US amongst communities of color. We have to highlight that this is reinforced through current circumstances, but there is, again, a unique history, and there's many scholars, again, who are doing this work. I highlight a few: Dorothy Roberts, Dr. Dorothy Roberts, Harriet Washington, Dr. Michelle Goodwin, who have really been at the forefront of talking about women's reproductive rights, women's reproductive autonomy in medical settings, and how what's happening currently with current abortion policies and other ways of discrimination and bias within healthcare settings really, again, just reflect the history and the embedded racism within this space. And we also want to highlight that there is an opportunity now with medical cohorts becoming more diverse. I experienced this teaching public health students, learning more about sexual minority health, for instance. I learned that, I co-learned with my students more about those areas. So that's really important, even if we weren't trained and learn this information as instructors, as providers, as practitioners, we can also turn to the next generation that often is more attuned to some of these issues, that also can discuss their lived experiences with health and social disadvantage, with these intersecting identities, and really being sensitive to the needs and the vulnerabilities and resiliencies of learners, and that there are different experiences of learners. And we see that right now during the COVID-19 pandemic, with learners who are caring for children, who are also caring for parents, and not enough flexibility and enough acknowledgement across our educational system in terms of how this might serve as barriers to their education experience. I'll end with just saying it's important that we really embrace cross-disciplinary collaboration. Again, COVID-19 is not just a healthcare issue. It's not just a public health issue. It's a bioethics issue. It's an issue related to social work and other professions. It's a transportation issue. It's an infrastructure issue. So we need everyone at the table to all address a common goal of delivering healthcare and preventive services to individuals that's timely, that's affordable, that's efficient, and that really improves their quality of life. And I want to end with a quote by Alice Walker. And I chose this particular quote because when we think about structural and systemic change, I think in some ways it can actually have the opposite effect. So individuals might feel like, oh, well, I'm not the structure, I'm not the system. The system needs to do better. The system needs to change. So it's important that we as individuals who make up these systems and these structures also interrogate our own biases, interrogate our perceptions about communities who may not have access to transportation. What are the stereotypes? Again, what are the embedded narratives that we think when we start engaging with communities? So we have to really focus on changing ourselves, because we cannot change or transform healthcare, public health, or any bioethics or any other field unless we first change ourselves. So here are some references that reflect some of the things that I discussed today. And I also included several resources for people who want to engage more with medical education and equity work, lots of conversations. I have a colleague, Dr. Tiffany Mayo, who actually is a graduate of Tuskegee University, and she's doing a lot of work right now in dermatology, highlighting the importance of understanding more about skin and hair of color and how there are historical inequities related to not only treatment, but engagement with populations in this way. The AMA strategic plan, structural competency work by John Metzel and others, the AMA Health Equity Guide, the paper that I discussed that our team led, and finally the AMA Health Equity Hub is also a very good resource. And I will end here and give people the opportunity to ask questions if there are any. And thank you so much for inviting me and for your time and listening.
Yes, thank you, Dr. Fletcher. Wonderful, thank you so much. Please put questions into the chat. We have one from Dr. Tracy Wilson, who asks just, is there any work in the space of the nursing voice and perspective with regard to health equity in minority communities that you are aware of?
That's an excellent question. And thank you for highlighting. I will be sure to add nursing in the future. So I really do appreciate that. A lot of my colleagues, I can really highlight that there are a lot of nursing colleagues right now. The National Institute of I think it's in our nursing research, has really been leading the initiatives, some of the anti-racism initiatives. Lots of nurses really advocating for better healthcare delivery. So yes, there's work in that space. I'm less familiar with some of the local initiatives, but certainly on a national level, there's movement in the field of nursing. And yes, we should continue to highlight the work of nurse scholars. There are several that come to mind for me. My colleague, Dr. Crystal Lambert from the University of Alabama at Birmingham, who's been doing a lot of work in the HIV and equity space based on her experience as a nurse practitioner. So important for the interdisciplinary collaboration with nursing scholars. So thank you for that question, Tracy.
You know what? We'll just take them in order. What are your thoughts on vaccine mandates, a triage based on vaccine status and the potential impact on health equity or inequity?
Yeah, so that's a good question. I certainly in the beginning of the pandemic, it seemed logical that we would have these mandates, and we've had other mandates throughout time. Of course, COVID-19 feels like new territory for everyone. But I had conversations recently with community members who felt that these vaccine mandates, again, perpetuated disparities. So there were individuals who felt that their economic survival was threatened by mandates and had really actually justifiable reasons for not wanting to get vaccinated. So I think, again, I don't have the answer. It's certainly attention. I think it really calls for more engagement, more work on our parts as practitioners, as researchers, to really have more conversations and implement interventions at the highest level in policies to support communities in decision-making and informed decision-making, and providing them with the resources that they need to receive vaccines. I think that's certainly key, and we haven't done enough. And we do have these policies. So ideally, we would have done much more before we're even at this point where vaccine mandates exist. And there are people who are being disadvantaged, who are traditionally marginalized. So this is certainly attention. We need more discussion, more dialogue. I don't have the answers, but I know that we certainly have to continue to engage communities.
Dr. Sadeki, do you want to jump in?
Yes. Thank you very much for letting me share my voice at this point. Thank you so much, Dr. Fletcher, for your insightful and inspiring message. Anytime I have the opportunity to listen to you, I feel elated and full of hope. I particularly want to thank you for the way in which you recognize all the knowledge domain and moral persuasions that need to come together in order for us to do this. It really does take a village to raise a child or resolve a particular problem. I sense the integrative way in which you have brought this together. And I just wanted to put my voice out there to thank you very much and for leading this effort in such an outstanding intellectual way. Thank you so much.
Thank you so much. And again, certainly could not do this without the support and intellectual contributions of colleagues and mentors and students. I definitely am committed to this work in a collaborative way. So, but thank you. I appreciate that. And thank you for your support.
One question that I see here, you talked about interdisciplinary work and you know, gosh, we need to add nursing. And there's at least one additional player in the United States, public and private health insurance. Any thoughts on how they might be able to actively address health inequity and healthcare inequity?
I mean, we have documented that, you know, certain insurance statuses and a lack of insurance and individuals who may not be documented also lack access to some of these resources. We have to think about the types of models that we're using. So for instance, Kaiser, some people are measuring differences in health outcomes based on different types of Yeah, and I think there, what I can really see, and again, health policy scholars will have more insight into this, but the way of delivering care that's coordinated is important, and care that's integrated. In my earlier work with HIV positive patients at some of these one-stop shop clinics, they're even being within the same clinics and having dental care and OBGYN care co-located, there was still a lack of seamless integration of these services to really address health in a holistic way. So again, I think it's thinking about health more holistically, and how can we really promote health equity based on the multiple needs. So not just medical needs, but social needs. So having case managers on board, connection with legal services and other types of services. So thinking about models that really have these aspects built in.
The question from the chat. The Dental Society trying to address the topic of diversity, equity, and inclusion. How do you have any advice how they might go about increasing acceptance of their new mission and policy, and how organizations are increasing the numbers of diverse individuals on, say, their boards and whatnot?
Excellent question. If there are any dentists or dental scholars in the audience, please feel free to jump in. But I'll just say this one thing. I think part of what we have to do, again, is acknowledge, so whether or not, and hopefully there's some, I think there's dental scholarship that really highlights discrimination and racism in dental settings. I can say in my work with HIV positive populations, lots of HIV positive women report having negative experiences with dental care issues, and whether or not that was just a communication issue, issues about, oh, I can't deliver care to you because you're HIV positive. And some people say, oh, it's because they needed to be on prophylactic antibiotics before they actually got here. And again, there's lots of room for training and lots of room for growth. Again, dental organizations should just do whatever studies, or just use whatever dialogue they have to acknowledge that this is an issue and work towards more training. And I think the piece that's really important when I talk about this interdisciplinary scholarship and health equity embedded, it's important that it's embedded in all disciplines. So some people feel like, oh, it's not relevant to medicine, or geneticists don't have to know about racism. It's relevant. It's certainly relevant. There's no aspect of health or any social aspect where health equity is not relevant. So yes, dental collaborations, training would be just as important. So hopefully, as the American Medical Association is producing all these great health equity materials, that there's similar materials and initiatives that happen within the dental space. And hopefully you're able to lead that work.
Thank you. We have a couple of hands. People have been raised their hands. Harold Schmidt.
Thank you very much. My name is Harold Schmidt. I'm an assistant professor of medical ethics and health policy at Penn. I also want to thank you for your work. You're really such an inspiration. I was thinking back to ASBH when your session, the one that you had with colleagues who you highlighted earlier too, was really for me one of the most inspirational ones. And I want to come back to this question of what progress we might make or might not make. I think you sort of rightly said we have commitments, but there are, I think, good reasons to be concerned. And I want to flag one piece that gets a little technical, so I put something in the chat for those who don't know. So in crisis standard of care and ventilator rationing, there are 5 large studies with more than 100,000 patients that show that dominant models disadvantage Black patients, right? So there's no question that the evidence is there that we know this. In many ASBH sessions, that was widely acknowledged among people who really are at the forefront of critical reflection. But by and large, the consensus was, well, yeah, but we don't really need to change anything right now. And we have 3 states that have recently activated crisis standard of care that use outdated versions of a guideline that disproportionately disadvantages Black patients in particular. So to me, that is a little shocking, because I first wrote an op-ed last spring. People said, let's not talk about this now, we're in the middle of a pandemic. Then I thought, that's weird, that's why we need to talk about it. Now you're trying to have this conversation, people are saying, well, we're coming out of it. What's the big deal here? So just wondered what your thoughts are. And I know that this clinical space is not your domain, but given you thought about the broader response, I wonder if you can just help me understand what's going on, because I find it insanely frustrating. And I'm just curious, both in terms of what your sense of optimism or lack thereof is, given the power of path dependency, as well as what that means, how that can inform what we need to do now.
Yeah, that's a wonderful question. I know that there was recently, I want to say, a meeting, the National Academies held a meeting and they talked about crisis standard of care. I don't know if there, should be some really important findings, and I'm sure a report that comes out of that. I have an article that I can share. My colleague, Dr. Virginia Brown, wrote an article for Hastings where she talked about the importance of integrating social determinants of health and collecting data, social determinant data within these settings to understand more about it. As I mentioned, part of really promoting health equity is collecting the data, knowing the intent of the data, and really documenting to promote an anti-racist praxis. So again, not necessarily a space that I work in, but I know that there are scholars that are certainly doing this work and really challenging the existing medical ethics model around this aspect. So again, happy to share that article. And I do believe that there should be some really good findings coming out of that recent meeting, which includes some bioethicists doing this work. Dr. Monica Peak is a physician ethicist at, I think Northwestern was also really involved in that recent meeting. It was a few weeks ago. So I think that's probably a great place to start. But yes, important to have people leading the conversation that are really sensitive to these determinants, these structural determinants, so that the conversation is framed in a way that is holistic.
Thank you. I want to get to as many people as we can. Dr. Camacho?
Hello, Dr. Fletcher. First of all, I just want to thank you so much for a wonderful presentation. Unfortunately, I had a meeting run late, so I popped in about halfway through, so I'm terribly sorry about that. Something that we've seen here sort of at the center in a lot of our community work, we engage with the Latinx population, Mexican Americans, people from South America. We partner with community-based organizations. One in particular has done some studies and some research into vaccine hesitancy and the Latinx population. And something that was found sort of preliminarily, this research hasn't really been come to the fore yet, is that the number one reason for vaccine hesitancy within this particular population here is fear, specifically fear about what the vaccine does and doesn't do. And what they've done is they've incorporated that information into their own vaccine rollout. So they partner with like community-based other hospitals in the area and stuff. And it's, it was really shocking to me, because when we think about the mass vaccine rollout and the way it typically occurs, like when I got my vaccine, there really wasn't an opportunity. This is now like probably March or so. There really wasn't an opportunity for me to ask a question. So it was just sort of, you drive up, show your QR code, and just kind of get in the queue. Now, had I asked a question, that would have been fine, I'm sure. But in thinking about sort of the infrastructure and the vaccine rollout, a lot of people of color, a lot of BIPOC communities don't have the luxury to do research on what an RNA vaccine does. And that's something that, so they lack that as a sort of resource. And another thing is time. Maybe not everyone has the time to go at that particular moment to go get a vaccine from say 9 to 5 p.m. Right. And so lacking time as a research within the BIPOC community. So anyway, I just wanted to sort of echo that and just hear your thoughts on things like time as a resource, knowledge as a resource within these particular communities.
Yeah, those are excellent points. And I think when we talk about the barriers, we might see who's actually getting vaccinated, but we don't understand those vaccination attempts. So there may be individuals who showed up at pharmacies and they were closed, or had an appointment and they were late for appointments and weren't able to get vaccinated. So I do think that there's some information that we need to fully understand the story, but I completely agree. Like there's lots of questions that we initially didn't answer as we were delivering information and messages. So recently someone came to me, they're like, so why did they start using some new technology with COVID? Like, this is really serious. Like, we should stick with what we know. And I was like, that's an interesting perspective. But again, having those conversations with communities earlier on would have really helped us to even anticipate some of these barriers. So I think it's just more of this reactive approach to delivering healthcare, to delivering health information and public health. And we have a long way to go to really strengthen the infrastructure so that we are ready within emergency responses. But you're certainly right. There is lots of fear. It's justifiable and understandable. And when you think about that in terms of the intersection with work mandates, we do have lots of conversations and things that we need to do to make sure that populations are protected. And even if that's just, again, trying to go out to communities who, because healthcare, that's a good point. Like, a lot of people don't interact with the healthcare system. And I talk to my doctor about vaccines, and people assume that everyone's having conversations and has access to providers and other health experts. It's just not the case, especially in this virtual environment when people don't have access to technology. So yes, more on the ground work, learning more from the leaders who are doing this work, Dr. Uche Blackstock, Dr. Alice Stanford, Dr. Aletha Maybank, many leaders have made a difference by just having a conversation with a person on the street. Why don't you want to get vaccinated? Asking the why, that's the important piece, understanding the why. We have to do more of that, because we can definitely move people from hesitant to acceptant. People are not, our behavior is very fluid. It's not static, and we have to keep that in mind. And I feel like sometimes that's lost in these conversations. In health behavior history, we always are working to change people's stage, but we have to understand where they are to begin with, and we haven't done enough work to really do that.
Thank you. It is 1 o'clock. I want to have the opportunity to thank you while folks are still here. Thank you so very much for this talk and for continuing to do the valuable work that you're doing. There were some requests for the information, the resources and references that you provided. And I believe we will have the recording up of this talk fairly soon, so people could scroll to that point in your presentation. But if there's another way for them to get that information from you, there have been some requests.
Okay, happy to share my PowerPoint presentation with some of the references. And thank you all for attending, and wonderful, thought-provoking questions. I think it's a risk of selling myself as like an interdisciplinary scholar. But amazing to have these questions, lots to think about as I continue to learn more and grow more. So thank you.
Thank you very much. If you have a moment, there was at least 1 or 2 more questions, but I understand you have a life and probably need to get back to it. So.
Yeah, I'm happy to share these. I can actually just. Okay, I can take a few more questions, but I'm going to try to share like the resources and the.
Very good. Yeah.
Thoughts.
The one question that I didn't notice, and I may have missed some, but was recommendations how to increase diversity in clinical trials. And, that, yes, people have been asking that question for quite some time. So any guidance would be helpful, but that's a tough one. Yeah.
That is the question. I mean, I think we're seeing lots of, there's a recent article published about the importance of Black researchers and Brown researchers and other BIPOC researchers leading a lot of this work. And again, as NIH rolls out its plans to really dismantle racism, I think really examining and investigating the leadership in a lot of these studies is key. We have some research on provider-patient concordance, but we don't really know enough about the influence or the impact of racial concordance with researchers, not just the people who are collecting the data, the research directors and the project coordinators, but also just having PIs that are Black and Brown, and how that might change that sort of engagement. So I think, again, there's a lot of space with, increasing this diversity. I think the earlier rhetoric was like, oh, we have to find these populations that are really hard to reach. But now that we're in a different place and acknowledging that there's so much more on the system and policy level that we need to do, we could possibly see some changes if we really start to implement and embed health equity in our strategies and in our approaches.
Wonderful. Thank you so much. The recording will be available soon through tulane.edu/bioethics. And we'll have, there are links to videos that we have there. So that's for folks who are asking where to access it. That's where it will be when it becomes available. Thank you so much again.
Thank you so much for having me. Everyone have a wonderful day.
Thank you.